Okay, this is a quick review for the MDC2 Exam 2. If you find that my recordings are helpful, just share them with another student to help them out too. So the normal range for pH, CO2, and HCO3. The pH is 7.35 to 7.45, CO2 is 35 to 45, and HCO3 or bicarb is 22 to 26. What is metabolic acidosis? It is an overproduction of ketone bodies in the kidneys. The causes of metabolic acidosis: DKA, renal failure, shock, aspirin overdose, sepsis, and starvation. Signs and symptoms of metabolic acidosis: headache, decreased blood pressure, hyperkalemia, changes in level of consciousness like confusion and drowsiness, warm flushed skin, nausea, vomiting, diarrhea, Kussmaul respirations, and bradycardia. Tests and findings for metabolic acidosis: decreased bicarb and decreased pH, high glucose, low sodium, high potassium, high chloride, high BUN, high CR, positive urinalysis with ketones, increased lactic acid, and EKG may reveal tall T waves, prolonged PR, and wide QRS. Treatment for metabolic acidosis: insulin, dialysis, electrolyte imbalances, respiratory compensation. Causes of metabolic alkalosis: vomiting, gastric suction, hypokalemia, long-term diuretics, Cushing's disease. Signs and symptoms of metabolic alkalosis: restlessness, decreased level of consciousness, dizzy, irritable, compensatory, hypoventilation, tremors, muscle cramps, tingling of fingers and toes, nausea, vomiting, diarrhea, and tachycardia. Tests and findings for metabolic alkalosis: increased bicarb and pH, low potassium, chloride, and calcium. ECG may reveal low T waves that merge with the P waves. Treatment for metabolic alkalosis: IV chloride, antiemetics, Diamox, DC gastric suctioning. Discontinue gastric suctioning. Respiratory acidosis: retaining CO2. Causes for respiratory acidosis: decrease in respiratory stimuli like a drug overdose and anesthesia, COPD, pneumonia, atelectasis, which is alveoli collapse, choking, sleep apnea, and rib fracture. Signs and symptoms of respiratory acidosis: hypoventilation, rapid and shallow respirations, dyspnea, headache, hyperkalemia, dysrhythmias, drowsiness, dizziness, disorientation, muscle weakness, hyperflexia, and bradycardia. Tests and findings for respiratory acidosis: elevated CO2, decreased pH, chest X-ray will identify COPD, pneumonia, pneumothorax, pulmonary edema, serum electrolyte, hyperkalemia, decreased DTR with high calcium. Treatment for respiratory acidosis: bronchodilators administer oxygen, improve ventilation, correct electrolyte imbalances, treat underlying infection with antibiotics. Respiratory alkalosis: getting rid of too much CO2. Causes of respiratory alkalosis: hyperventilation from fear, anxiety, mechanical ventilation, or high altitude. Signs and symptoms of respiratory alkalosis: seizures, deep rapid breathing, tachycardia, decreased or normal blood pressure, hypokalemia, numbness and tingling of extremities, lethargy and confusion, lightheadedness, nausea, vomiting. Tests and findings for respiratory alkalosis: decreased CO2, increased pH, ECG may reveal dysrhythmias, hypokalemia, and hypocalcemia. Treatment for respiratory alkalosis: treat underlying cause first, antibiotics and replace electrolytes, administer oxygen. GERD, backward flow of stomach contents into the esophagus, known as regurgitation, chronic and more serious condition that arises from persistent gastroesophageal reflux. Risk factors for GERD and what foods to avoid. Caffeinated beverages, coffee, tea, and cola, chocolate, nitrates, citrus fruits, tomatoes, and tomato products. Alcohol, peppermint, spearmint, smoking tobacco products, calcium channel blockers, anticholinergic drugs, NG tube placement, and high levels of estrogen and obesity. Signs and symptoms of GERD. Dyspepsia, which is indigestion. Regurgitation may lead to aspiration or bronchitis. Water brash, which is hypersalivation. Dental caries, which is severe cases. Dysphagia. Adenophagia, which is painful swallowing. Globus, which is feeling of something in the back of the throat. Pharyngitis, coughing, hoarseness or wheezing at night. Chest pain. Pyrosis, which is heartburn. Epigastric pain. Generalized abdominal pain, belching, flatulence, and nausea. How to diagnose GERD. Upper endoscopy, biopsy, esophageal manometry. Ways to treat GERD. Laparoscopic Nissen fundoplation, which is LNF, is minimally invasive surgery, MIS, and is standard surgical approach for treatment of severe GERD. Endoscopic therapies, drug therapy, lifestyle changes. Oral cancer. Oral lesions that are red, raised, and eroded that do not heal within 2 weeks. Basal cell carcinoma. Oral cancer that occurs primarily on the lips and is related most closely to sunlight exposure. The lesion is asymptomatic and resembles a raised scab. With time, it evolves into characteristic ulcer with a raised pearly border. Basal cell carcinomas do not metastasize but can aggressively involve the skin or the face. Kaposi sarcoma. Oral cancer defined as a vascular tumor appearing as a raised purple, reddish, or brownish nodule or plaque, which is usually painless. It can be found on the hard palate, gums, or tonsils. It is most often associated with acquired immune deficiency syndrome, which is AIDS. Signs and symptoms of oral cancer. Bleeding from the mouth, poor appetite, compromised nutrition status, difficulty chewing or swallowing, unplanned weight loss, thick or absent saliva, painful oral lesion that is red, raised, or eroded, thickening or lump in the cheek. How to diagnose oral cancer. A needle biopsy or an incisional biopsy, CT or MRI, may be performed to determine if there is metastasis or if staging is needed. An MRI is useful in detecting perineal involvement, perineural involvement, and evaluating thickness and cancers of the tongue. Common surgeries for oral cancer. Glossectomy, removal of the tongue. Common surgeries for oral cancer. Laryngectomy. Common surgeries, removal of the larynx and tumor. Common surgeries for oral cancer. Mandible resection, removal of part or all of the mandible. Common surgeries for oral cancer. Maxilloectomy, removal or part of all the hard palate. Common surgeries for oral cancer. Microsurgery, reconstruction of the mouth, throat, or mandible with body tissue from the patient. Common surgeries for oral cancer. Mohs micrographic surgery, removal of cancer on the lip by taking of thin slices until no cancer is left. Common surgeries for oral cancer. Neck dissection, removal of the lymph nodes in the neck with or without muscle, nerve tissue, and veins. Common surgeries for oral cancer. Pedicule or free flap reconstruction. This is repair of the mouth, throat, or neck after a tumor is removed. Common surgeries for oral cancer: tumor resection. This is remove an entire oral tumor with some surrounding tissue. Stomatitis and mucositis. Inflammation of the oral cavity. Painful, inflamed ulcerations that erode tissue integrity of the mouth, placing the patient at high risk for bleeding. Primary stomatitis. Aphthous stomatitis is non-infectious stomatitis, herpes simplex dermatitis, and traumatic ulcers. Secondary stomatitis. Infection by viruses, fungi, bacteria in patients who are immunocompromised or from chemo, radiation, or steroid therapy. Signs and symptoms for stomatitis: lesions, coating, cracking, dysphagia, and pain. Treatment for stomatitis: clotrimazole troches, nystatin suspension, chlorhexidine, lidocaine, diphenhydramine liquid, aluminum or magnesium hydroxide. Avoid spicy, salty, and acidic foods. Hiatal hernia. Protrusion of the stomach through the esophageal hiatus of the diaphragm into the chest. Hiatal hernia type 1. Sliding hernia. The esophagogastric junction and the portion of the fundus of the stomach slide upward through the esophageal hiatus into the chest, usually as a result of the weakening of the diaphragm. Hiatal hernia type 2. The gastroesophageal junction remains in its normal intra-abdominal location, but the fundus and possibly portions of the stomach's greater curvature rolls through the esophageal hiatus and into the chest besides the esophagus. Hiatal hernia type 3. The gastroesophageal junction and the fundus both herniate through the hiatus, with the fundus lying above the gastroesophageal junction. Hiatal hernia type 4. The colon, spleen, pancreas, or small intestine is found in the hernia sac instead of the stomach. Signs and symptoms of a sliding hiatal hernia type 1. Heartburn, regurgitation, chest pain, dysphagia, belching. It's similar to GERD. Signs and symptoms of paraesophageal hernia types 2 through 4. Feeling of fullness after eating, breathlessness after eating, feeling of suffocation after eating, chest pain that mimics angina, worsening of symptoms, and recumbent position. Diagnosis of hiatal hernia. Barium swallow study for hiatal hernias, esophagogastroctoduodenoscopy, or high-resolution manometry with esophageal pressure topography for sliding. Treatment for hiatal hernia. Type 1 is treated medically, while 2 through 4 are treated based off type and severity. Surgery for hiatal hernia. Transabdominality. Abdominally. Open procedure or laparoscopic Nissen fundoplication, which is LNF, is a minimally invasive surgical procedure commonly used for hiatal hernia repair. Surgery for hiatal hernia. Transthoracically. Prepare the patient undergoing a transthoracic approach for a chest tube and a nasogastric tube, which will present after surgery. Hernia education. Consume a soft diet for about a week. Avoid carbonated beverages, tough foods, and raw vegetables that are difficult to swallow. Remain on anti-reflux medication as prescribed for at least a month or per your healthcare provider's recommendation. Do not drive for a week after surgery. Do not drive if taking opioid pain medication. Walk every day, but do not do heavy lifting. Remove small dresses 2 days after surgery and shower. Do not remove wound closure strips until 10 days after surgery. Wash incisions with soap and water. Rinse well and pat dry. Report any redness or drainage from the incisions. Report fever of above 101, nausea, vomiting, or uncontrolled bloating or pain. For patients over the age of 65, report temperature elevations above 100. Keep your follow-up appointment with your surgeon, usually 3 to 4 weeks after surgery. Esophageal cancer. Squamous cell carcinomas of the esophagus are located in the upper two-thirds of the esophagus. Adenocarcinomas are more commonly found in the distal third at the gastroesophageal junction and are now the most common type of esophageal cancer. Risk factors for esophageal cancer: alcohol intake, diets chronically deficient in fresh fruits and vegetables, diets high in nitrates and nitrosamines found in pickled and fermented foods, malnutrition, obesity, especially with increased abdominal pressure, smoking, and untreated GERD. Signs and symptoms of esophageal cancer: persistent and progressive dysphagia, most common feature, feeling of food sticking in the throat. Odynophagia, which is painful swallowing. Halitosis, chronic hiccups, chronic cough with increasing secretions, hoarseness, severe persistent chest or abdominal pain or discomfort, anorexia, regurgitation, nausea and vomiting, weight loss, often more than 20 pounds, changes in bowel habits, diarrhea, constipation, and bleeding. Diagnosis of esophageal cancer. Esophagogastroduodenoscopy with biopsy, PET scan, and CT scan. Treatment for esophageal cancer: chemo, radiation, photodynamic therapy, esophageal dilation, endoscopic therapies, targeted therapies, esophagectomy for surgery. Upper GI bleed. Medical emergency with rapid deterioration. Priority for GI bleed. ABCs. What to monitor in GI bleed. H&H. Treatment for GI bleed: nasogastric tube placement and lavage, endoscopic therapy, interventional radiologic procedures, and acid suppression can be used to control acute bleeding and prevent rebleeding. Signs and symptoms of a GI bleed: bright red or coffee ground vomitus, which is hematemesis, melena, which is tarry or dark sticky stools, decreased hemoglobin and hematocrit, decreased blood pressure, increased heart rate, weak peripheral pulses, acute confusion in older adults, vertigo, dizziness or lightheadedness, syncope, which is loss of consciousness. Peptic ulcer disease results when GI mucosal defenses become impaired and no longer protected. The epithelium form the effects of acid and pepsin. Duodenal ulcer. It's the most common type. The most common type is deep, sharply demarcated lesions that penetrate through the mucosa and submucosa into the muscularis propera, which is the muscle layer. The floor of the ulcer consists of a necrotic area residing on granulation tissue and surrounded by areas of fibrosis. A gastric ulcer. Develop in the antrum of the stomach near acid-secreting mucosa. When a break in the mucosal barrier occurs, such as that caused by H. pylori infection, hydrochloric acid injures the epithelium. Stress ulcer. Acute gastric mucosal lesions occurring after an acute medical crisis or trauma, such as sepsis or a head injury. In the patient who is NPO for major surgery, gastritis may lead to stress ulcers. Patients who are critically ill, especially those with excessive burns, a curling ulcer, sepsis, which is ischemic ulcer, or increased intracranial pressure, which is Cushing's ulcer, are also susceptible to these ulcers. Stress ulcers are associated with lengthened hospital stay and increased mortality rates. Therefore, most patients who have major trauma or surgery receive IV drug therapy to prevent stress ulcer development. Bleeding caused by gastric erosion in the main manifestation or acute stress ulcers. Signs and symptoms of an ulcer: sudden and sharp pain, melena, hematemesis, tender and rigid abdomen. Diagnosis of an ulcer: serologic testing, esophagogastroduodenoscopy, nuclear medicine scan. Treatment of an ulcer: proton pump inhibitor, avoid caffeinated beverages, endoscopic therapy, NG tube for bleed, minimally invasive surgery. Gastritis: inflammation of the gastric mucosa. The most common form of chronic gastritis is type B gastritis, caused by Helicobacter pylori infection, or H. pylori. Prevention of gastritis. Eat a well-balanced diet and exercise regularly. Avoid drinking excessive amounts of alcohol beverages. Do not take large doses of aspirin or other NSAIDs or corticosteroids. Avoid excessive intake of coffee, even decaffeinated. Be sure that foods and water are safe to avoid contamination. Manage stress levels. Stop smoking. Protect yourself against exposure to toxic substances in the workplace. And seek medical treatment if you're experiencing symptoms of gastroreflux. Signs and symptoms of gastritis. Rapid onset of epigastric pain and dyspepsia, hematemesis, and melena. Treatment of gastritis. Esophagogastroduodenoscopy or rapid urese testing for H. pylori infection. What imbalance occurs from an anxiety attack? Respiratory alkalosis, excessive loss of CO2. In an anxiety attack, would the pH be high, low, or variable? High. During an anxiety attack, would the CO2 be high, low, or variable? Low. What imbalance occurs during sepsis? Metabolic acidosis, hypermetabolism, overproduction of lactic acid. During sepsis, is the lactate level high, low, or variable? High. During sepsis, is the pH high, low, or variable? Low. During sepsis, is the bicarb high, low, or variable? Low. During sepsis, is the CO2 low, high, or variable? Variable. During sepsis, is the potassium high, low, or variable? High. During high altitudes, what imbalance occurs? Respiratory alkalosis, excessive loss of CO2. During DKA, what imbalance occurs? Metabolic acidosis, oxidation of fatty acids, production of ketone bodies. In DKA, is the pH high, low, or variable? Low. In DKA, is the CO2 high, low, or variable? Variable. What imbalance is present if Kussmaul respirations are seen? Metabolic acidosis, a sign of respiratory compensation, breathing faster, which means decreases CO2, which increases the pH. What imbalance occurs during starvation? Metabolic acidosis, oxidation of fatty acids, production of ketone bodies. In starvation, is the bicarb high, low, or variable? Low. What imbalance can occur if the patient presents with multiple rib fractures? Respiratory acidosis, retention of CO2 from shallow breathing related to the rib fractures. Would DTRs be high, low, or variable with rib fractures? Low. What imbalance results from diarrhea? Metabolic acidosis, excessive loss of bicarb. With diarrhea, would the pH be high, low, or variable? Low. With diarrhea, would the bicarb be high, low, or variable? Low. With diarrhea, would the CO2 be low, high, or variable? Variable. What imbalance occurs with vomiting? Metabolic alkalosis, excessive loss of hydrogen. With vomiting, would the potassium be high, low, or variable? Low. With vomiting, would the calcium be high, low, or variable? Low. In vomiting, would the DTRs be low, high, or variable? High. What imbalance can occur from gastric suctioning? Metabolic alkalosis, excessive loss of hydrogen. With gastric suctioning, would the pH be high, low, or variable? High. With acute asthma exacerbation, what imbalance can occur? Respiratory acidosis, retention of CO2 due to poor gas exchange. With asthma, exacerbation, would the pH be high, low, or variable? Low. With asthma exacerbation, would the CO2 be high, low, or variable? High. What imbalance can occur from kidney failure? Metabolic acidosis, under elimination of hydrogen and under production of bicarb. With kidney failure, would the pH be high, low, or variable? Low. With kidney failure, would the potassium be low, high, or variable? High. What imbalance occurs from opioid overdose? Respiratory acidosis, retention of CO2 related to respiratory depression related to poor gas exchange. With opioid overdose, would the CO2 be high, low, or variable? High. Name the imbalance for salicylate overdose, which is aspirin. Metabolic acidosis, respiratory alkalosis during compensation. What imbalance occurs from seizure activity? Metabolic acidosis, overproduction of lactic acid. With seizure activity, would the bicarb be high, low, or variable? Low. What imbalance occurs with hyperventilation? Respiratory alkalosis, excessive loss of CO2 related to increased gas exchange. With hyperventilation, would the potassium be high, low, or variable? Low. With hyperventilation, would the pH be high, low, or variable? High. What imbalance occurs with an overingestion of antacids? Metabolic alkalosis, excessive bases ingestion. With overingestion of antacids, would the pH be high, low, or variable? High. With overingestion of antacids, would the CO2 be high, low, or variable? Variable. What imbalance occurs from hypoventilation? Respiratory acidosis, retention of CO2. With hypoventilation, is the bicarb high, low, or variable? Variable. With hypoventilation, is the CO2 high, low, or variable? High. With hypoventilation, is the pH high, low, or variable? Low. Which lab value indicates that a client is acidic? Low pH. When analyzing ABGs, what is the first step? Label the pH. When analyzing BAG, what is the second step? Determine the primary cause. Which of the following are expected findings with acidosis? Bradycardia, decreased DTR, high potassium. Which of the following are expected findings with alkalosis? Low potassium, increased DTR, low calcium, tachycardia. Which of the following are expected findings with alkalosis? Positive chivostexine, paresthesia. True or false? With respiratory acidosis, the O2 saturation is likely to decrease, whereas the respiratory alkalosis, the O2 saturation is likely to be unaffected. True. What assessment technique would you use for upper GI? Abdominal examination starting with right upper quadrant, inspection, auscultate, palpate. Who performs the percussion and palpation? APRN. What is stomatitis? Oral cavity inflammation, ulcerations are most common form. Recurrent aphthous ulcers. Most common oral cancer. More than 90% are squamous cell carcinoma. Early sign of mouth cancer. Mucosal erythroplasia. What are the risk factors for oral cancer? occupational hazards, periodontal disease, HPV-16. What to notice in assessment for oral cancer. Oral hygiene, determine appetite, nutrition status, thorough inspection of oral cavity. GERD. Its most common type of GI disorder, occurs as a backward flow of the stomach contents into the esophagus. Hiatal hernias increase risk for GERD. During hailing, Barrett's epithelium and esophageal strictures are concerns. GERD surgery. Heartburn, chest pain, asthma. So GERD signs and symptoms are heartburn, chest pain, asthma, hoarseness, pneumonia, dyspepsia, indigestion, odynophagia, and dysphagia. GERD diagnosis. Barium swallow, EGD, pH monitoring examination, and esophageal manometry. Hiatal hernia. Diaphragmatic hernia, protrusion of the stomach through the esophageal hiatus of the diaphragm into the chest. Surgery is similar to GERD. Signs and symptoms, I'm guessing, is what that is. Gastritis. Inflammation of the gastric mucosa. Two types of gastritis: erosive versus non-erosive. Acute versus chronic gastritis. Acute is short-term, chronic is long-term. Chronic gastritis types: type A, type B, and atrophic. Etiology and genetic risk of gastritis. H. pylori, long-term NSAID use, local irritation from radiation therapy, accidental or intentional ingestion of corrosive materials, autoimmune causes. Peptic ulcer disease. Mucosal lesion of stomach or duodenum, occurs when mucosal defenses become impaired, epithelium not protected from effects of acid and pepsin. Types of ulcers: gastric, duodenal, and stress. Ulcer complications: hemorrhage, perforation, pyloric obstruction, intractable disease. Peptic ulcer genetic risk and etiology: H. pylori, NSAIDs, other substance that alters gastric secretions. Gastric cancer: adenocarcinoma, can be asymptomatic until detected in advanced stage. Gastric cancer etiology and risk: H. pylori, history of pernicious anemia, gastric polyps, chronic gastritis, eating pickled foods, nitrates from processed foods, and salt added to foods, prior gastric surgery, more common in males than females, and those over 50.